Great. Yeah. So age of the patient is just 44, 45 years. He's diabetic for 15 years. The weight, if you can see, is 93 kg. He's hypertensive. He has high lipid levels. And because of this stress, because of all this, he feels very stressed out. He's non-vegetarian, has a sedentary lifestyle, and along with that, look at the cholesterol levels. It's 260, TG 300, LDL 140, creat 1.8, very disturbing to him, and a BMI of 36. His fasting hovers around between 150 to 160, and his PP hovers around between more than 200 to 250. And with this, when I already told you that this is the type of treatment he's having outside before coming to me, along with all the diabetic specific nutrition that we talked about, anti-anxiety pills, multivitamins, and he's tried almost every weight management method in the past. You talk about Orlistat, you talk about non-approved herbal products for weight reduction. It didn't help him. He even tried intermittent fasting and everything, but all attempts for weight loss has failed in him in the past. The one most important thing in him was he had constant cravings of having sugars or high fat food or high calorie food, and with that he always used to have peaks and troughs of insulin. Now when this patient comes to me, what is the choice left to me? I am not left with anything because almost all the oral anti-diabetic drugs are already with him. He's on 20/20 insulin. What am I going to do? I either have a choice of stepping up glimepiride from 4 milligram to 8 milligram, or shifting from glippi to glipizide or gliclazide, or either adding a long-acting or an ultra long-acting basal insulin. That's what I'm left with. So what I am doing with this patient is I'm just putting him on Tirzepatide, and look at the change the patient is having. As usual, what do I aim in this patient? I aim a A1C control, I aim weight loss, I aim lifestyle management. And trust me, as one of the previous speakers said, this is not a job which only a diabetologist or a bariatric physician can do. In the previous session, we have understood clearly it's a teamwork. So along with me, who works as a very good nutrition therapist, an educator, an art of living therapist, and a nutritionist. Together, we talk to this patient and put him on Tirzepatide and look at the changes he has. So the patient was put on 2.5 milligram, and almost 6 doses of 2.5 milligram were given to him. If you look at the graph, just see the dip that is there right from April to mid-May. So this means that 2.5 milligram has worked very well in him. At the end of June and July, the A1C of the patient is 7, and the weight is reduced from 93 kgs to 80 kgs. It is not 96, it is 93. So approximately 14% of weight loss is there in this patient. So what do we achieve by the end of 3 months? From 2.5 to 5 milligram, 2.56 doses were given, followed by 5 milligram, which he was taking till now. Recently, we have stepped up to 7.5 milligram. We achieve in having fasting blood sugar from 160 to 100, prandial less, LDL from 140 to 110, triglycerides from 300 to 180 around, and the most impressive and astonishing thing is that his creatinine comes down from 1.8 to 1.5, which none of the studies have so far demonstrated, because all the trials of Tirzepatide are still ongoing, and there are lots to discover more in terms of heart failures and in terms of nephropathy. And another interesting fact, since he's hypertensive as well, his BP comes down from 160/90 to 110/70 without antihypertensive doses. Right at the end of June, we reduced first his olmesartan 20 to 10 and then stopped it at the end of July, and today he's off antihypertensive medication. So this is the summary of this patient, and this is how the patient looks like. And I'm pretty confident about that this patient is not just happy because his weight is lost, because he's looking very good. Of course, that is a very good criteria, but the most important happiness of the patient is that his glycemic levels are very, very less, and he is no more on insulin, which he was for past 4.5 years, and his A1Cs have come down, and the prescription size has come from this big to this small. He's not on voglibose, he's not on repaglanoid, his metformin doses are reduced, and this is how he looks now. So this is the patient with type 2 diabetes and obesity. The second part of approved indication of Tirzepatide in my patient is a very, very interesting young female who's just 27 years, and just 6 months before coming to me, she had a pulmonary embolism, and she keeps on hovering with a pulmonary artery pressure of 50. She gets breathless while walking. She is not able to manage her weight by any means. She tried almost everything. Lifestyle management helped her reduce weight in the past, but because of her breathlessness, she couldn't do much of exercises, and she's very disturbed because she's just 27 years. And what disturbs her most is not her obesity, not her pulmonary embolism. Yes, these are disturbing factors, but how is she going to get married? What is her life going to be in future? What is going to be the fertility in future? She has PCOD, she has disturbed menstrual periods, and off-label, when she works in her office, she's always looked at as if she has come from a different world, and that makes her put under more anxiety, stress, and everything that we don't see upfront in the patients that have obesity. So in this patient also we started Tirzepatide. She was on metformin 500 milligram and rivaroxaban 20 milligram for her pulmonary embolism, along with diuretics for increased PA pressure. We started Tirzepatide, and along with my team of managing diet in my own way, managing exercises and teaching them high protein diet, counseling them about anxiety, depression, taking them over to a different right, trying to give them a life which is different from what they were having. And you see the patient does achieve a weight loss, and if you see the picture of the patient, you will be really excited to use the molecule in such type of patients. Now, so from 104, this patient comes to 89 kgs, a significant weight loss just with 5 milligram of Tirzepatide in almost April, May, June, July, 4 months. And if you see the graph in this patient as compared to the graph which was there in the previous slide, the dip in 2.5 milligram from 104 to 94 is so fast, which means that if 2.5 milligram is given to a non-diabetic, the response is way better. And this patient was given 2.5 milligram for almost 8 weeks, and then she was shifted to 5 milligram. This is in accordance with the Surmount trial that was there, Surmount 1 trial, which was there only for weight loss, and there's a significant weight loss in this patient. To my surprise, the diuretics were stopped in this patient, and as she reduced weight, I was able to reduce the rivaroxaban doses also as the time was passing on. And finally, the patient is just on 10 milligram of rivaroxaban, no diuretics, and her periods are very regular, along with she looking more beautiful. Her quality of life becomes very good as she walks along, and the confidence levels is increased along with the weight loss and loss of BMI. And the first picture is the picture when she has come first to me. The second picture is after 6 to 8 doses of just 2.5 milligram, because she was losing way faster with 2.5 milligram alone. So we shifted after 8 doses to 5. And the third picture is the picture where I ended up my slide. Recently, when I was preparing my slide, this was the presentation that was prepared a way back. So I had only 3 pictures. When I was just about to come here, I just called her up. I said, can you send me a recent picture of yours? And the last picture is the one which is a recent picture, which is not in the graph. Means now she is just from 4 more kgs less from the last weight that is put up in the third picture. And this is the achievement we get in our clinic using this molecule. And it just not just satisfied us in obesity management, it satisfied everybody around us, whether you talk about my team of obesity management, patient herself or himself, and their relatives. I have enormous pictures and experiences in weight management. Now this is a lady who was shifted from semaglutide to Mounjaro, and you can see this picture was when she was taking 14 milligram of semaglutide for past 2.5 years. And after we shifted for Tirzepatide, in the same dress she posted her picture, and this is the picture. Another one, this is the fastest and the maximum weight loss patient of Tirzepatide in my obesity clinic, where in just with 2.5 milligram, I continued for 2.5 to 3 months, and she kept on losing. She won't go to 7.5 milligram, I'm pretty sure. She was a model, and after her childbirth, she kept on gaining. And now that's her picture where she's rethinking of going back to her profession. And this is the age where she's at 47 years of age. Another picture, again, this was one person who was fed up with diabetes, obesity, and a lot of comorbidities. And if I keep talking, it's going to be the whole day when I show the pictures, because I have more than 150 plus patients only on Tirzepatide. Forget about other molecules that are approved indications of weight management. I think I convince my audience and my chairperson that yes, of course, the SURPASS and the SURMOUNT trials are variably in agreeing terms with the real world data that we use in India. Thank you so much for your patience.